Okay, good morning, everybody, and welcome to today's webinar. Just to introduce our panelists today, we are having two topics, COVID-19 and pregnancy. This is our part 3. And today, really, we are going to focus on what causes the rapid deterioration in the immediate postpartum period. And that will take the first 30 minutes. Then we will have our colleagues from pediatrics. And today we are going to focus on COVID-19 and the neonate. On the on COVID and pregnancy, of course, our session chair is Dr. Lois Ombacho, we all know her. And the speakers who will talk about COVID-19 and pregnancy is Dr. Anne Barasa. She's a pathologist and lecturer, Department of Human Pathology, and head of immunology unit at the University of Nairobi. We will also have Dr. Edwin Walong, who is an anatomic pathologist and lecturer, Department of Human Pathology, University of Nairobi. Our pediatric colleagues, we have Dr. Mudhomi Bebo. He's a medical officer, pediatrics, Kenyatta National Hospital. He will give us the case presentation, and that will be followed by case discussant, Dr. Anne Marie Macharia. She's a pediatric and infectious disease specialist, Kenyatta National Hospital. And part of the panelists, we have Dr. Anne Beatrice Kihara, Dr. Patrick Olang, Professor Mondi Ogutu, Dr. Mary Beth Maritim, and myself, Dr. Rose Koske. You are welcome, and we hope to have a very lovely and lively discussion today. Thank you very much. To start us off will be Dr. Anne Barasa. Dr. Anne, welcome.
Thank you, Dr. Koske. Okay, kindly confirm that you can see my presentation.
Dr. Anne, mic check.
Can you hear me?
Yes.
Okay, and my presentation is visible?
Yes, it is.
Okay, thank you. So I'll start us off just to discuss and probably put forward some hypotheses on what causes rapid deterioration in the clinical condition of severe or critically ill COVID-19 pregnant patients in the immediate postpartum period. So just as a background, this is the common presentation of these patients. You have a critically ill COVID-19 pregnant patient. Delivery is successful. In most cases, the newborn is stable relative to the gestational age at delivery. But then what follows is a stormy immediate postpartum period characterized by ICU admission, severe morbidity, and in most cases, mortality. So what we are asking is, what is the cause of this postpartum exacerbation in illness in these patients? What does the evidence say? So there's little data currently. There are few case reports and case series that are published. The cause is not really known, cannot be extracted from what is published currently. So I will propose some hypotheses based on one, is this exacerbation caused by peculiarities to the changes that occur in pregnancy, or is this just the natural course of the disease based on the underlying risk factors that we know predispose patients to severe COVID-19? So this is the first hypothesis, that the postpartum exacerbations are caused by physiological adaptations to labor, delivery, and the immediate postpartum period. So we know that during pregnancy, there are certain physiological changes that take place in the mother. And definitely there will be reversion of these changes after delivery. And one of the significant changes are hemodynamic changes. So shortly after delivery, there is fluid shift between the interstitial, intracellular, and intravascular compartments. During and just after the delivery process, there's a catecholamine surge and effects of that. There's release of inflammatory mediators within the endothelium. There's hemodilution caused by that fluid shift, which causes hypoalbuminemia. And I'm sure we all know that low albumin can be used as one of the biomarkers of severe COVID-19 disease. And then there's also thinking that the process of delivery itself could lead to release of certain cytokines, including interleukin-6, that is a pro-inflammatory cytokine. So these changes in the setting of a severely ill patient with systemic infection would definitely increase the exacerbation or increase the dysregulated inflammatory process that is already ongoing because of the underlying infection. So are these physiological changes the ones that put these patients at higher risk of severe COVID-19 even after delivery? These changes would increase the chances of endothelial dysfunction, increase the chances of these patients developing pulmonary edema. There have been reports of myocardial edema and cardiac dysfunction. And then if we focus specifically on the lungs, you do get injury because of the viral infection. There will be injury because of pulmonary edema and other pathological changes. And it's thought that in this setting, this also predisposes the patients to secondary bacterial infections or pneumonias. So this would exacerbate the illness leading to ARDS. The second hypothesis is that this is the natural cause of the disease. This pregnant patient has COVID-19, has other underlying risk factors that would predispose them to developing a cytokine storm. I'm sure by now we all know what a cytokine storm is. So this is dysregulated hyperinflammatory process, which ultimately leads to multiple organ failure. The underlying pathologies that we get uncontrolled production of cytokines. Where do these cytokines come from? So you have the SARS-CoV-2 virus, infects the epithelial cells within the airways. And we know with viral infection of host cells, you do get some damage to these host cells. These cells start to produce reactive oxygen species. They also produce cytokines. Epithelial cells can produce cytokines. So you get activation of certain intracellular signaling pathways that would lead to cytokine production. As the cells are getting damaged, probably maybe due to viral egress, you get changes on those cells that release certain signals, what we call the damage-associated molecular patterns that are recognized by the innate immune cells, macrophages and the neutrophils. The virus and the viral particles themselves also express pathogen-associated molecular patterns that can be recognized by these cells using the pattern recognition receptor. So these cells become activated. As they're activated, they also secrete cytokines, okay? We know that the macrophages are important in activating the adaptive immune response. So they produce cytokines as well as present the viral peptide antigens to T cells. The cells become activated. What do these cells do when they're activated, especially the T helper cells or the CD4 positive T cells? They also secrete cytokines that have different functions. So you're getting a lot of cytokines being produced from various cells. They're used to communicate between cells, activate cells so that they can perform their effector functions. For example, the cytokines produced by T helper cells ultimately should activate the macrophages so that they can get rid of infected cells better. Some of these cytokines are chemokines, so they will cause an influx of these inflammatory cells from the blood to the tissues where you're having the infection. So in a patient who doesn't have risk factors for underlying disease, or when you have a well-controlled or coordinated immune response, the activation of these various immune cells should lead to clearance of the pathogen. But what happens in some of these patients is that you have other factors that would delay clearance of the virus or of virus-infected cells. So you get a continuing cascade of cytokine production. And the effect of these cytokines is that they can be released in an endocrine fashion and exert their effects on different organs. And then you end up having multisystemic inflammation or sepsis. And with sepsis, you end up getting tissue damage to several organs. As the cells in these organs are damaged, they also release the damage-associated molecular patterns that activate your mononuclear phagocytic cells, and the cycle continues. So when we think about this, and we think about some of the other physiological changes that take place in pregnancy, specifically to do with the immune system, we know that there is some immune modulation in pregnancy just to ensure that the mother can tolerate the fetus. Okay, so there's fetal-maternal tolerance. This is characterized by a shift from a T helper 1 phenotype to a T helper 2 phenotype. So there's a skew to a T helper 2 phenotype, which is usually mediated by or characterized by an antibody-mediated response, as opposed to a T helper 1 phenotype that is characterized by a pro-inflammatory response. And this is the response we usually have to get rid of pathogens. So it's thought in that setting, as well as other changes that take place, for example, a reduction in the numbers of circulating natural killer cells, an increase in the number of T regulatory cells, that there's a sort of immune suppressive state, which could result in altered clearance of infected cells. As much as we expect the innate immune response to be the first immune response that would get rid of viral infections, you get a better and more effective clearance when we activate the adaptive immune response, so the T lymphocytes, which would then activate your B cells to produce antibodies. So in this sort of situation where you cannot have a good T helper 1 pro-inflammatory response, it's thought that this increases the risk of these patients developing severe COVID-19 disease. The other question we can ask ourselves, because as much as pregnant patients have more of a predominant T helper 2 response, do we then have a reversion back to a T helper 1 phenotype after delivery? At what point does that occur? Could that be the one that is responsible for the pro-inflammatory response that comes into play after delivery? We don't know. Regarding the immune modulation in pregnancy, it's still not known whether that is protective against severe COVID-19 in pregnant patients, or that is what is a risk factor for susceptibility to severe infection. So just something to think about. The third hypothesis is a multisystem inflammatory syndrome. So this is also a hyperinflammatory response that is rare, and it's seen after infection. So it's a post-infectious immune-mediated condition that is associated with COVID-19. There are several organs that are involved, and actually it's thought that there may be clearance of the virus from the respiratory tract, but persistence of viral infection in other organs. And people have actually been able to isolate the virus from some of these organs like the heart, lungs, kidneys, and so forth. So multisystem inflammatory syndrome was initially described amongst children and adolescents, and it was called MIS-C. It was shown to manifest 3 to 5 weeks after COVID-19, even if these patients had asymptomatic infection. The clinical features are varied, but predominantly they tend to present with shock, cardiac dysfunction, abdominal pain, and on laboratory evaluation, they have elevated inflammatory markers. So multisystem inflammatory syndrome has also been described in adults. There are some case series and case reports in literature. And amongst adults, it's been shown to occur closer to the time of acute infection. So you don't have a very long lag of 3 weeks post-infection. It occurs in the sickest patients and in those with most comorbidities. So probably these patients have other underlying risk factors that would make them present with this multisystem inflammatory syndrome. It's a severe illness, so they would require ICU care, and it can be fatal. As the name suggests, multiple organ systems are involved. but we don't know much about the pathogenesis of this disease and the long-term effects among adults. This slide just shows some proposed mechanisms of MIS-C and MIS-A, formerly called PIMS-TS. So one is that there could be impaired interferon signaling. We know interferons are the earlier cytokines that are produced when there's a viral infection, and they tend to cause an antiviral state. So they prevent infection of neighboring cells. For example, if there's one cell that is already infected, or make it more difficult for the infection to progress. And actually, some of the patients who develop severe COVID-19 have been shown to have autoantibodies against the type 1 interferons, that's interferon alpha and beta. So ultimately, this would delay the clearance of the virus. So because it would end up causing propagation of the infection, and then you get the massive cytokine upregulation and the unchecked inflammation that comes after that. The second proposed mechanism is impaired antigen presentation, regardless of the mechanism, which would lead to antibody production, but in this case, you're not getting functional antibody. So the functional antibody would be neutralizing antibodies that would end up preventing viral infection, continued viral infection of uninfected cells. So you end up with non-neutralizing antibodies, probably binding antibodies, that maybe could cause antibody-dependent enhancement of disease. So these antibodies end up being the ones facilitating viral entry into certain cells. We don't know. The other proposed mechanism is production of antibodies, but this would be cross-reactive antibodies with other host cell antigens or epitopes. So they're autoantibodies, which would end up causing inflammation through other processes, for example, activation of complement and so forth. So it's not really known, but these are the proposed mechanisms of MIS-C and MIS-A. This is my final slide, just giving the case definition of multisystem inflammatory syndrome in adults. So it's a severe illness that requires hospitalization in a person aged 21 years or older. They may have a positive test for either current or previous SARS-CoV-2 infection. So it could be a PCR-based test, it could be a rapid antigen test or an antibody test, either during admission or in the previous 12 weeks. There is severe dysfunction of one or more extrapulmonary organ system. So whether it's the heart, whether there's VTE, whether it's the liver, the kidney, there's lab evidence of severe inflammation. But then what has been seen in adults is that there's absence of severe respiratory illness. So this is quite different from what we see in active COVID-19 disease with a cytokine storm. So usually the adults don't have respiratory distress. Thank you. I'll stop there and Dr. Walong can proceed with the pathology.
Unmute. Right. Thank you very much, Dr. Baraza, for that talk. Let me put my screen on. Let me put my presentation on full screen. Right, Dr. Baraza, do you see my full screen?
Yes, it's visible.
Thank you. So what I'll take you through in this talk is what we are currently doing and what we have seen. The information I present here is purely preliminary because we still have a lot of analysis to do, but just a sneak preview of what we have, what we do. So this is Dr. Wasike, one of our pathology residents who should be a pathologist soon. And we, as part of our research team, we are interested in identifying or applying minimally invasive tissue sampling for cause of death determination, and to obtain appropriate specimen, target specimen that can facilitate additional research work to evaluate the hypothesis that you have examined. And why the minimally invasive autopsy? Mainly because this is the technique where we can obtain fairly sterile tissues and other specimens for a laboratory-informed cause of death. So it will facilitate diagnostic testing within the laboratory. We can archive these specimens, and we always include histopathology so that we can properly interpret whatever diagnostic tests that we have performed. But anyway, I'll take you through a few cases so far. And this data is still it's still raw. We still haven't analyzed much. I know Dr. Lois Acheng has requested me to add in additional clinical information. What I'll inform is that most of these deaths occurred within 72 hours, mainly in the ICU setting, and some of them had a much shorter post-mortem interval, having come in from from referral, having been referred from other facilities. So what are we seeing? So when we look at our cases, we do not have, I have examined so far about 8 cases. I'll present a summary of 6. And in this summary, we are seeing relatively young women who die of severe COVID-19 related pathology. And in some of them, for example, case number 1 and 3, the death is occurring in the 3rd trimester with an intrauterine fetal death in situ. So what we did was to perform minimally invasive autopsies and obtain various tissues for culture. And the culture specimens we perform include brain, lung, liver tissues, blood, and cerebrospinal fluid. And we have grown various bacteria from those sites, range, and the most common one, and we see this across all the range, is Klebsiella pneumonia. However, we also do see certain coagulase negative staph aureus, but I've put it in red because we still have additional analysis ongoing, mainly to distinguish contamination from infection. And the histopathology that we do perform in these organs is to help us identify the underlying disease process and whether there is inflammation related not only to these infectious agents, but also to the COVID-19. And indeed, we do see that the lung is a major focus where we tend to see a lymphocytic pneumonia and a diffuse alveolar damage, the lesion which clinically you describe as acute respiratory distress syndrome. But then most of these women will also have various other systemic diseases, and the next most affected organ being the liver, where we see fatty livers quite a bit, tend to be microvesicular in pattern. And some of them may have CNS diseases we have seen. So case number 2, for example, we did see inflammation, which is consistent with viral meningitis within the brain itself, not only meningitis, but encephalitis, in addition to the features in the lung that are consistent with COVID, but also bronchopneumonia, which definitely shows that the bacterial infection was important in the death, as it were, in that case. So again, additional cases that we have here. Again, as you can see, most being a maternal mortality group, the mortalities will definitely be 40 years and below. And we have a 25-year-old here, 32-year-old here, 41-year-old here. And again, as I mentioned, what I've put in red is because we need to do more work to distinguish whether, because typically coagulase negative Staphylococcus aureus are seen in individuals who have indwelling catheters, and sometimes there may be a contamination or contaminants from the processes of sampling. Being an autopsy study, we are alive to that fact. But we do see certain organisms such as Candida albicans, whose site we cannot really tell, And in additional autopsies that we have performed, we've found in other groups, particularly adults, we have found Candida albicans in the gastrointestinal tract, and it's picked up as a bacteremia as well. So we may see this, but tends to be a fairly rare finding. And then, of course, the main finding in a lot of these individuals, again, involve the lung and the liver. But case number 4 is quite interesting because the inflammation that we are seeing involves the meninges, but we do not, and the inflammation is really mild. We tend to have more vascular pathology within the meninges, characterized by thrombosis and normal lungs. So some of these mortalities are not the typical, COVID type acute lung injury related deaths, but we do see various CNS related pathology. And in case number 5, there was also additional trauma related to this. So of course, we think the cause of death is not directly COVID in case number 4 and in case number 5. Well, in case number 4, the COVID pathology appears to be mainly vascular and the meninges or the meningeal coverings of the brain. Of course, looking at the actual pathology, most pathologists who are working with COVID first were astounded by the fact that the inflammation we see is really mild compared to what we see in other severe viral pneumonias, where we see a lot of lymphocytes within the interstitium, and this tends to be quite mild. We really have to look for these hyaline membranes within the lung. And sometimes in the lung, Dr. Baraza may have mentioned it, we do see a lot of erythroid precursors in circulation, including an increase in the number of megakaryocytes, as you can see here. The bone marrow and COVID-related pathology and mortality may be another area that maybe Dr. Ann Baraza would maybe allude to in the Q&A session. And when we look at the bone marrow, because these are individuals who have severe lung pathology with hypoxic disease, systemic, there's almost always an erythroid hyperplasia. And we also tend to see a lot of megakaryocytes, which we find also in circulation and lodged within the pulmonary circulation. And the contribution of these immature circulating megakaryocytes, erythroid precursors, may first of all shows how severe the hypoxic pathology is, so to the point that there is a host response to it through a compensatory hyperplasias. But then again, the impact of this in the microvascular circulation, their role in thrombosis is also quite important. Now, this is a core biopsy of the lung, and it's in low power. I apologize for the non-pathologists here. But what we're looking at here are 2 main pathologies combined in this specimen of lung, where we had identified Klebsiella. And this is a typical bronchopneumonia, where we're seeing neutrophils within the alveoli, but at the same time, we're also seeing an increased number of type 2 pneumocytes and hyaline membranes also within the alveolar walls here, in addition to the viral pneumonia, which in COVID tends to be fairly patchy and appears, we really have, sometimes we do have to look for it to really find it. And this is a combination of not only the bacterial lung disease, but also the interstitial pneumonia. The reasons for the bacterial lung disease as a coinfection here, of course, still under investigation. We are looking at various reasons. First is antimicrobial resistance that may have occurred, especially in these cases that are referred to our institution. And we're also looking at the synergistic role between the viral pneumonia or the viral related DAD and bacterial pathology, as we have seen variously in other disease processes. For example, in influenza A, it is not unusual to find co-infection of Streptococcus pneumoniae with influenza A, H1N1, and that synergistic relationship results in more severe immunopathology or pathology within the lung. And that may also be occurring in some of the situations. But of course, the caveat is that before we generalize these findings, we want to see how important these are to the overall COVID mortality. This is one of the CNS pathologies, and this is a meninges. And again, I apologize to the non-pathologists and also to pathologists because my images are not as clear as I'd like them to be. But what we do note is that within the vasculature of the meninges here, there are increased circulating precursor cells, mainly erythroid precursors, and sometimes some megakaryocytes. But then again, there's inflammation involving the whole of this meningeal lining, but it's a patchy lymphocytic inflammation that suggests that there is an inflammatory response to injury right within the meninges over here. And this will suggest that there is a viral infection or direct viral infection of the meninges. And this is unusual compared to what we see in non-COVID related pathology. We will do the statistics later, but just from basically, based on our opinion, we do see that in pregnancy-related COVID, especially postpartum, there are cases of inflammation at very interesting sites, such as meningeal inflammation. We've seen a case of encephalitis, and we intend to perform immunohistochemistry to see whether we can truly localize the virus to these sites. And in other autopsies we performed, particularly full autopsies, we've seen foci of infection within, or foci of inflammation within the liver and also within the kidneys. So it suggests maybe a viremia with different sites of infection here. So from this brief series, we think that maternal cases, especially postpartum cases, may have high COVID viral loads and systemic disease. So we are seeing demonstrated inflammatory foci within the brain, and we've observed in other sites. In these cases, most of these women may not have, for example, if we compare with other adult mortalities, where we tend to see older individuals obese with severe atherosclerosis, we do not seem to see this among these women. Instead, we see fatty liver. And looking at the liver, I think the liver, there should be a link between fatty liver disease or liver dysfunction, as Dr. Baraza has talked about, albumin and so on, and cardiogenic pulmonary edemas may contribute to this. Now, the association of multi-drug resistant bacterial infections is an area we will look at in a bit more detail. Maybe in a different talk, we'll discuss this. And Dr. Lois Acheng is here and she will make a comment on this. We still can't act on this information from a clinical perspective, and we still need antimicrobial stewardship to be maintained. We have seen coagulase negative Staph aureus, probably related to indwelling catheters, but we are still working to elucidate these pathologies. So, and then Candida, likely due to GI pathology, and we are still looking at the contribution of other co-infectious pathology, such as influenza A, RSV, and other common respiratory infectious pathology in COVID. So finally, the research priorities that we have and we think we should be looking into, and I would like to encourage my colleagues to write protocols focusing on this. We need to identify whether there is SARS-CoV-2 viremia, either early or late in these cases after delivery, and whether this is related to multisystemic viral infectious sites such as liver, brain, kidney, in addition to lung, and whether this can actually define a postpartum immune reconstitution inflammatory syndrome, which we've seen in other infectious diseases. And for us in pathology, we will use minimally invasive and complete diagnostic autopsies to investigate this. And we hope that in the clinical areas, you will also consider looking for viremias in various sites as well in your series. again, the role of bacterial co-infections and their role in sepsis is really important in COVID-19, and we need to look at it. We are using histopathology to distinguish contamination from infection. If you're in clinical practice, we expect maybe you could further maybe increase the use of microbial diagnostics. KNH has a good system right now, and a lot of investment in there from bioMérieux, and we think that if you could submit cultures before antimicrobial therapy, and of course other areas that Dr. Lois Acheng will talk about, then this is an area that we may need to look at in a lot of detail. My pulmonology colleagues have been performing bronchoalveolar lavage in certain situations, and this specimen should definitely be cultured and also submitted for cytopathology and histopathology. We are looking at liver diseases in pregnancy. Look at pregnancy-related fatty disease, pregnancy-related periportal inflammation, and its role in severe COVID-19 pathology, especially when the liver is concerned. We're also thinking of coexistent eclampsia or HELP syndrome, and whether COVID is actually mimicking eclampsia and HELP syndrome in these patients. And this is something we need to look at. Immunosuppression and its role in the immune reconstitution inflammatory syndrome or severe systemic infections, as Dr. Baraza has talked about, may need to be examined. We're using not only corticosteroids, but also there is use of additional, the so-called disease-modifying agents, such as tocilizumab, and what is its role in as an immunosuppressant and its role in severe systemic infection or immunosuppression as well. And finally, looking at the placenta would identify whether especially to distinguish eclampsia from COVID, we may need to include placental pathology in this work. And no work is complete on maternal disease without examining the neonate. So we are also contemplating neonatal autopsies. Right, so of course I'll stop there, and my work is currently supported by the Meets Alliance Foundation and Institute Mérieux, and I'm happy to work closely with KNH, University of Nairobi, and of course the CHAMPS project in working on this, and my colleagues in OBS and Gynae, and internal medicine, and of course pathology. So thank you very much, and I'll stop here.
Thank you very much, Dr. Walong. I mean, this work is so incredible and so impressive. Congratulations to you and the team. We are hoping even to see further results as time goes on. And maybe I just wanted to make a few comments in addition to what you presented. I think the results are very sobering and really point to areas where we can think about quality improvement so that our patients don't get to the point where they're getting all these resistant bugs or candidemias. So one, I think the issue that we're seeing a lot of resistant, or at least for the few patients we have resistant Klebsiella, we have to think about what are some of the risk factors for this. And maybe just going back to some of the things you highlighted. Many of our critical care units now, we're beginning to have Klebsiella pneumonia and multi-drug Klebsiella pneumonia as a predominant organism, even overtaking E. coli, which previously has been sort of the predominant bug. So what gets us to this point? And we have to think about the journey of managing a patient. Many patients who are dying, especially in ICU, have been in hospital for a long time. They may have been exposed to significant doses of steroids. They may have been on tocilizumab, both of which we know may be immunosuppressive. And these patients may have been exposed to significant durations and a number of different antibiotics. And those are all risk factors for acquiring resistant bugs. We also have to think about invasives that our patients have. So if you have patients who have a urinary catheter that they do not need, if patients have central lines that stay in too long and are not well taken care of, then we put our patients at risk of getting resistant bloodstream and other invasive infections. The same thing follows for candidemia. Often when you have a patient with invasive with candidemia, then these are patients who usually have had central lines for a long time or other catheters for a long time, patients who've been exposed to extensive antibiotic, and patients who may have had significant immunosuppression. So we really have to think about management of our patients from the word go, so that our patients are not dying because of, you know, things that would should have been prevented from the word go. So I guess the other question I had is, you know, if you think about what the pathology showed and what the microbiology showed, so there's a lot of bacteria, but in a lot of the pathology, we see all this lymphocytic pneumonitis or meningitis. And I wonder if there's any plan to look for SARS-CoV-2 in the various tissues, so that you see what is explaining this predominant lymphocytosis within the tissues. Dr. Olong, yes.
Right, thank you very much. And I really appreciate those comments. Now, the question on what we will do with the tissues, we do plan to perform virological testing of tissue using immunohistochemistry. And with immunohistochemistry, we use antibodies against SARS-CoV-2. We are looking for good commercial antibodies that reliably can identify or we can use on a tissue slide to try to localize the specific virus or viral proteins within specific sites and visualize it using under a microscope on the actual histological tissue itself. And we are in the process of acquiring these antibodies, and we know that once we have that, then we can look at the hypothesis of multifocal infections. And perhaps that can give us evidence of bacteria, of viremias that may probably occur in this group compared to others. So that is work in progress. I'm working closely with my mentors at the CDC's infectious disease pathogen laboratory, who are able to also, in addition to perform immunohistochemistry, in situ hybridization, where we look for genetic material of the virus within the specific tissue to localize it. We can also extract the nucleic acids, amplify, sequence them, and characterize them further. But that is definitely work in progress and work that we intend to do as part of this project. Yeah. Right.
Thank you, Dr. Olong. I think sorry, did I cut you off?
No, you didn't.
Okay, thank you so much. I think we really look forward to seeing even further results from your work. It's really fantastic. And maybe I just had a question for Dr. Anne Barasa as we wait for further questions to come in. I think one of the things you mentioned is in this definition of a multisystem inflammatory syndrome in adults, it seems that the lung was not considered sort of a predominant organ that was involved. The interesting thing, though, is that in most of our patients who are dying with COVID, ventilation is often a big challenge. So at this point, these are patients who we are barely able to ventilate. And from a clinical perspective, usually have such significant lung involvement. When they do the scans, there's such severe involvement, what severity scores that are often maybe 70, 80% or above. And I'm just wondering about this definition and why they've left out, the significant clinical issues around lung and ventilation. Dr. Barasa? Yes.
Thank you, Dr. Ombajo. I think if you're having patients who have this systemic hyperinflammation and they have lung involvement, it's more likely to be a cytokine storm as opposed to the MIS-A, because in the reports that are published, they actually don't see much of the lung involvement. And I think the same thing has been seen in children. And that's why they think the underlying pathology would be that these patients are able to, so they have SARS-CoV-2 infection, they're able to clear the pathogen from the lungs, but then there's persistence of the virus in some of the other organs, which is what leads to the hyperinflammation in those organs. I don't know whether we have, for example, you have seen any patients in our setting, adults who may have Miss A, because I know the pediatricians have seen quite a number of children presenting with the same.
I think we probably haven't intentionally gone out to diagnose. And now that, as the awareness is increasing, we'll be watching out for some of the symptoms. I mean, you have patients who end up hypotensive with renal insufficiency and other things. And maybe this is the time to really document what we're seeing clinically as well. I guess one of the things I wanted to ask for the pediatricians here, I see Professor Gutu, Dr. Koskei, in terms of the patients who deteriorate rapidly post-delivery, are there any predictors that you may have noted, either pre-delivery? I know many times, and you mentioned last week, when we delay delivery, then those are patients who are unlikely to do well. But is there any profile of patients that people can look out for that would even advise which profile of patients you're very aggressive about from the word go in terms of delivery, in terms of thinking about cytokine storms? I don't know if you could share some of your observations around that. Professor Gutu? Or Dr. Koskei? Okay, we'll try and get them. I think Dr. Koskei may be having some challenges with our audio. So we'll try and get them, and maybe you can just think about who are the patients that we need to be most concerned about. So keep the questions coming in the Q&A. If there are any things that you'd like us to ask and would like us to, Dr. Barasa and Dr. Along to elaborate on, please keep them coming. They'll still be around with us, and at the end we'll answer more questions. Thank you very much, Dr. Barasa and Dr. Along. And I think maybe one of the questions you could ask. Okay. Dr. Along was just making a comment in the chat that making the diagnosis of MIS in adults may be difficult. The vascular events may be difficult to determine and may not easily be distinguished from, other coagulopathies that may be associated with other issues. So autopsies will continue to be useful. I think Dr. Along is still campaigning for us to ask for a lot more autopsies in our patients, and that's well noted and very well taken, Dr. Along. So allow me now to invite the pediatrics team. Dr. Anne-Marie is here. I don't know, Dr. Anne-Marie, are you the one who's going next, or we'll have the case presentation next?
Good morning. We'll have the case presentation by Dr. Muthomi first.
Okay. Karibu sana, Dr. Muthomi. You can go ahead and share your slides.
Okay, good morning.
Morning, we can hear you. You can put on slideshow, please.
Okay. Okay, so I'm going to be, hello, can you see my screen?
Yes, we can. Are you able to put on slideshow, please?
Yes, I've put it on a slideshow.
Yes, excellent, thank you.
Okay. All right, so I'm going to be presenting a case on a neonate with the COVID-19 in Ward 3C at Kenyatta National Hospital. So the patient was AW, is a patient we had on 16th of August this year, and the patient was 26 days, it was a female, and the patient was discharged after 7 days. They lived, or rather they live in Zimmerman, and the informant was the mother. So the baby presented with a 3-day history of difficulty in breathing, cough, and fever. And these symptoms were preceded by flu-like symptoms, where the baby had a running nose and nasal blockage for about 2 or 3 days prior to the onset of symptoms. The cough was wet. It was had no diurnal variation, and it was associated with episodes of difficulty in breathing. and hotness of the body, which was mildly relieved by paracetamol. And the mother reports that she also had similar symptoms because they live in the same house. She had flu-like symptoms a week prior to the baby getting those symptoms. But otherwise, the baby was feeding well, had normal bowel movements. They had gone to a peripheral facility at Zimmerman where they had been started on oral amoxiclav with very minimal improvement. And then, so they had taken the amoxiclav for about 4 days before being referred to Kenyatta for further management. So this was the index admission. And in the birth history, the baby was born at term at 38 weeks at St. Francis Community Hospital at Kasarani. It was a spontaneous vertex delivery. The birth weight was 3.3 kilos and she cried immediately. There was no history of admission to NBU. Immunization was up to date as the PACAP schedule. This baby was the firstborn of the mother, and the mother is 19 years old. She's a housewife with no NHI currently. So on examination at the presentation, the baby was quite tachypnic with a respiratory of 68 breaths per minute, heart rate of 123, but the temperature at the time of taking was 36.8, but this was after giving paracetamol. When they initially reported, they had a fever of about 37.6. Saturations were also low at about 84 on room air. And in general examination, this baby was sick looking, but had no jaundice, had no dehydration, no cyanosis, no lymphadenopathy. Okay, so in the physical examination, the baby in the central nervous system, the baby was alert, and the neck was soft, pupils were equal and reactive to light. In the respiratory system, we had the positive findings because the baby was in a mild distress, had a flaring of Alanasi, there was lower chest wall in drawing, and there was a bilateral rhonchi and transmitted sounds. So this baby was put on now that picture together with the low oxygen saturations. This baby was started on oxygen at a pediatric emergency unit before transfer to the ward. But otherwise, in the other systems, there are no positive findings. So we also did some investigations when they came in. We did a full hemogram, and I've just highlighted a few of the findings in the full hemogram. The white cell count was elevated at 17.57. So we had a leukocytosis and a neutrophilia of 10.93. The lymphocytes were at 5.34. Had a HB of 10.5. MCV was normal at 82, sorry. Platelets were also normal at 263. The UECs were also, they are not remarkable. The LFTs we also did an LFTs and they were also normal. The albumins were within normal, they were at 37. We also took a swab for COVID, PCR, which came back positive the next day. So this baby at this time was already admitted at Ward 3C, and we had started on management for severe pneumonia. We are on Expengenta for 7 days and oxygen therapy. We are also doing a paracetamol because sometimes they had spiking fevers. At this time, the mother was also breastfeeding the baby exclusively because the baby could feed. And so after completion of the 7 days, the baby recovered and the oxygen demands were quite low. So we were off oxygen. And we actually discharged this baby to go on with the home-based care at home, and they were to come back to the clinic, although they haven't come back yet. But otherwise, we discharged a stable baby. Okay, so that is the end of the presentation. Thank you.
Thank you very much, Dr. Muthomi. Maybe we'll hand over to Dr. Anne-Marie, then we can take questions once you're done. You can put down your presentation.
Okay, thank you very much, Dr. Muthomi, for that presentation. We decided to present that patient because this has been typical of the neonates that we have received who have followed a fairly benign clinical course. I'm going to discuss clinical management of neonatal COVID. Like you saw for that patient, it was fairly straightforward, actually indistinguishable from our usual neonatal sepsis. And the baby did well on just expangentamicin and oxygen therapy. So I'll get into my presentation. Okay. All right, so this is the outline of my presentation. First, I want us to discuss delivery for babies of mothers who are COVID positive. And then again, we will recap breastfeeding guidelines because we always seem to get many questions around that. Then we'll touch on neonatal COVID infection before finally closing with a recap on COVID vaccines in children. So when we have a COVID positive mother, what do we need to do? So testing, first of all, should be prioritized for women who are symptomatic. And as we've seen in the webinars we've been doing, these women have a high rate of CS delivery. So prenatal steroids are recommended for the women who are at risk of preterm delivery, even going as far as 36, 37 weeks plus. And then ideally, the delivery should be carried out in a room that has negative pressure. And the healthcare workers in there should be limited to those who are caring for the mother-baby dyad in order to minimize exposure. So the PPE that needs to be used by the pediatrician who's receiving the baby includes an N95 mask. They can wear a shield or they can use goggles. They should have a surgical gown and gloves, which are part of the normal precautions that we take. So what gives greatest risk of transmission from the baby to the healthcare worker? So the nurse or the doctor who is receiving this baby. There should be caution when you're doing aerosol generating procedures. Most babies will come out crying and just with some drying and stimulation, they will cry. But for those who need resuscitation, you may need to use a T-piece with mask ventilation. You may need to use bag valve ventilation. You may need to be suctioning, for example, if there has been meconium aspiration, and you may need to use CPAP. So those are procedures that would be aerosol generating, hence the use of your N95 mask, the goggles, and the shield. So while carrying out your resuscitation, a two-person technique is preferred. So you have one person, for example, securing the mask, doing a nice C and E grip, making sure that there's a tight seal around the baby's nose and mouth. And the second person is actually then delivering the bagging. If you need to intubate the baby, where it is available, you can use a videolaryngoscope. This will reduce maybe the number of attempts that you need to make. It will make visualization clear, and the baby will be less likely to be coughing or distressed while you're trying to do the intubation. The baby should then be placed in a closed incubator for them to be taken either to the newborn unit before the mom is settled, and they can then be rooming in. Procedures like skin to skin and delayed cord clamping, which are standard in normal deliveries, will be done based on the mother's clinical condition. So if the mom is stable, then the skin to skin and delayed cord clamping should still occur. We still want to initiate breastfeeding within the first half hour to 1 hour of delivery. But if mom is unstable, then the baby should be taken in a closed incubator, and we can look at feeding options, including replacement feeding or perhaps using expressed breast milk. Of note, it's a very small percentage of infants who actually test COVID positive in the 3 days to 1 week after birth. And from one US large survey, it was only 1.6 to 2% of infants. So moving on to the care of the COVID positive mother-infant pair. So how do we think this neonate gets infection? So there are lots of theories, none of them quite proven. Some people have talked about intrauterine transmission. So just touching on what my colleagues in pathology have said, do we actually have a COVID viremia? And if that viremia is significant, then theoretically you could have hematogenous spread through the placenta with inhalation of the viral particles, either from the amniotic fluid or they're ingested by the fetus. But so far, data has not really supported this mode of transmission. Another mode is thought to be maybe intrapartum, where the baby, again, is exposed to the infected secretions, including the blood, the feces, the amniotic fluid, and there is either aspiration or ingestion of those viral particles. But again, these two, like I say, at this point, seem to account for very little to almost none of the transmission. Most of the transmission to the neonate is thought to occur in the immediate postpartum period from respiratory secretions. So note that this could be coming from the mother. This could also be from other family members or healthcare workers. Yeah, often I've received calls from colleagues when a mother is being discharged and other family members have tested positive for COVID, or the mother herself has tested positive for COVID, and then what should you do? So this is what is thought to be the mode of transmission, with the postpartum transmission probably playing the biggest role. So how do we care for these newborns in the context of COVID-19? A global survey done and published in the BMJ in March of this year showed that these were the findings from this global survey, looking at the care of small and sick newborns during the COVID pandemic. And they interviewed over 1,000 healthcare workers in 62 countries. And these were their findings. Over 50% reported that evidence-based interventions such as kangaroo mother care, that is where especially preterm infants have skin-to-skin contact with both parents, and it has been shown to improve bonding and actually improve growth. Such practices were discontinued or discouraged. 2/3 of them did not allow mothers with confirmed or suspected COVID to practice the routine skin-to-skin contact, which we know is very important for the establishment of the microbiome for the child. 1/4 did not even allow breastfeeding, even by uninfected caregivers. Yeah, so early on in the pandemic, there was a lot of panic and mothers would just be separated from their babies. As healthcare workers, 85% feared for their own health and 89% experienced increased stress. And there was separation of the mother-baby diet for both COVID-positive mothers, 50% of them, and in 16% of those for unknown status. And this has had an impact on moms being able to establish breastfeeding, which we know is so important for the baby's survival. So data has shown, like I've said, that neonatal COVID infection is rare. And the rates of infection don't appear to be really affected by the mode of delivery. It is not increased when you have a vaginal, for example, versus a CS delivery. It is not affected by the mode you decide to feed the infant with, or having a mother who is confirmed or suspected to have COVID. And we'll look in a bit of detail at the symptoms that the neonates may present with, but they have signs and symptoms common to many other neonatal conditions. They have fever, lethargy, a runny nose, cough, some difficulty breathing, and poor feeding. So I'll then move on to, so how should we care for these babies and what should happen for the feeding? All neonates born to mothers with suspected or confirmed COVID should be considered as suspects when test results are not available. So test the neonates, regardless of whether they have signs or symptoms. They should still room in with the mothers, observing strict IPC measures. So the baby should still be in a cot next to the mother. While the mother is feeding, she should wear a surgical mask. She should observe hand hygiene. There's no evidence for her even having to wash the breasts. And while she's not feeding the baby, they can be separated by a distance of 1.5 to 2 meters, and the baby possibly placed behind a screen, and the mother continues with the masking if she's able to tolerate it. Exclusive breastfeeding should still be encouraged. And mothers suspected or confirmed to have SARS infection should not be considered of being a risk to their infants if they have already met the criteria for de-isolation. So just like we're treating the other patients in hospital, even if they remain symptomatic, the CDC guidelines now dictate that 10 to 14 days later, the patient is not having viral shedding, they are not infectious, so they are not at risk of continued transmission even to their neonates. What is not recommended? Neonates should not have face masks. Masks are not recommended for children younger than 2 years. Infant face shields can be used for the younger children, but that is in the setting of maybe them being used in school and certainly not for neonates. We should not discontinue interventions such as skin-to-skin care or even delayed cord clamping where we are able to continue to do so. And there should be no routine separation of newborns from their mothers. So in summary, breastfeeding should continue, should still be initiated within the first hour of birth where possible, and rooming in as a practice should continue in the hospital. So just looking at neonatal infection and coming back to the case that was presented by Dr. Muthomi, there are three main types of presentations, usually early onset neonatal sepsis, late onset neonatal infection, and there is now description of neonatal MISC. Like we have said, this is only for a very small proportion of neonates, less than 2%. And this is thought to be due to their immature immune systems and reduced expression of ACE2 receptors in the placenta and even in their own respiratory passages, and possibly some passive transfer of maternal IgG, particularly in the third trimester. So majority of our babies, we are thankful, have had mild infection and have really been, the case that he presented has been typical of the neonates. We have actually also had asymptomatic neonates coming in. Like I remember there was a baby who was there purely for phototherapy, and the baby next to them tested positive for COVID. So we had to transfer both of them into our isolation unit in the ward, and the baby undergoing phototherapy, despite testing positive for COVID, remained completely stable and was discharged without any intervention over and above their phototherapy. So looking at the spectrum of neonatal infection, the first one is early onset neonatal COVID. This usually happens 2 to 7 days after birth. Of note, like I said, majority of these children will actually be asymptomatic, but a small percentage who present with symptoms will present with temperature instability. So children may either be hypothermic, they may have a low-grade fever, or they may have a high-grade fever. Again, there may be loss of interest in feeds, or they're just too lethargic to be able to feed. They will have nasal congestion, so the coryza, they will have nasal discharge, they may have flaring of the alanase. Their breathing may be affected, so usually a tachypnea and a bit of cough. They're also presenting more commonly than adults with gastrointestinal symptoms, including diarrhea and vomiting. The baby may have lethargy, and you may notice cyanosis, either of the extremities, and very rarely, at least for those who have mild early onset COVID, you can get, sorry, what am I thinking of? You can get the digits actually turning black, yeah? So we have had one baby, though he was out of the neonatal period, who did present with that sort of presentation. So in summary, 20% of them will be asymptomatic, 40 to 50% just mild respiratory symptoms, and it's only 40% who will have severe respiratory distress. Typical lab findings, our baby just had leukocytosis with a neutrophilia, which was more suggestive of a bacterial infection. Babies may also have a lymphopenia, thrombocytopenia, and raised inflammatory markers. The management for these children is supportive, so feeding them, NG tube if the respiratory distress is marked, resuscitation using IV fluids, and providing oxygen therapy, which may be either by nasal prongs, mask, or CPAP. If the child requires endotracheal intubation, this happens more often in the setting of a baby who is premature and has respiratory distress syndrome or has meconium aspiration or other pathology. We then have a group of children who present with late onset neonatal COVID. These children tend to be admitted 3 to 35 days after birth. Again, presentation will be similar, only that these children tend to be sicker. And these are the babies who are more likely to have acquired infection in the postnatal period, either from a mother, a healthcare worker, or another caregiver. So they may be COVID negative early on, but then by the time they're coming in for admission with these symptoms, you find that their COVID PCR is positive. Of note is that they may also have some cardiovascular symptoms, either a tachycardia or a low blood pressure. So again, that is just a summary of what I've said. Their blood picture may also be the same. There may be more raised inflammatory markers, including the CRPs, the LDH, and the management remains the same. It is still supportive fluids and oxygen. In children, we do not have evidence for use of antivirals or steroids, but I did come across a case report for a 22-day-old child who had presented with late onset sepsis. This was in the US. And when the child continued to deteriorate, he received remdesivir, and the remdesivir was well tolerated, and the baby recovered well and was discharged at about day 34 of life. So now there is this multisystem inflammatory syndrome that is now being described in neonates. I was surprised to hear from Dr. Barasa that it's being also now seen in adults. Again, this seems to be sort of after the acute COVID period. Note that this is still primarily a syndrome found in older children, where the median age is 5 to 9 years, and only a very small percentage will present in the neonatal period. So again, the baby will have mostly cardiorespiratory findings. So there will be a myocarditis, elevated troponins and BNP. On echo, you may find coronary aneurysms or left ventricular dysfunction. In their bloods, low fibrinogen with raised D-dimers, thrombocytopenia, neutropenia, and lymphopenia. The baby may have respiratory findings, they may be hypoxemia, and on chest X-ray or imaging, you may see pulmonary infiltrates. They may also present with persistent pulmonary hypertension. The babies have feeding intolerance, so there'll be a neck-like presentation, that is necrotizing enterocolitis, where the babies do not tolerate feeds, and sometimes you're getting villus or even bloody aspirates with a distended abdomen. They may experience acute renal injury with hyponatremia, oliguria, renal failure, and this may lead to anasaka. And there may be evidence of either maternal infection, which could be ongoing or there in the past. Like I said, it is a hyperimmune syndrome that is coming after the acute COVID period. So we've talked about the first points. How do we manage this child? Again, very few cases reported. There was one case I came across again in the US of a 49-year-old baby, so outside of the neonatal period, who presented with what looked like neonatal MISC, and the baby received hydrocortisone. The baby also received pulse methylprednisone, but continued to deteriorate and only improved when they were given intravenous immunoglobulin. And the risk factors really for a baby progressing to this are unknown. So why did I decide to present this whole spectrum? Majority of the babies are falling within either category 1 or 2, so really indistinguishable from the usual early onset neonatal sepsis. If you do find a child who is presenting with what looks like MISC, this is tending to happen when we are having a wave. So getting such a child tells you that there are very many people infected within the community, probably asymptomatic. So we were seeing children with MISC when we had our third or fourth wave during this July to August season. So we should have a high index of suspicion when we know we have a lot of COVID in the community, and we see children and neonates presenting with this unusual syndrome, and there is history of COVID exposure within the household. Please note that the COVID PCR at that point may be negative, but if there is history, then think about MISC, because giving IVIG to such a child may actually be life-saving. There is a COVID antibody test available. Its sensitivity is not high, but again, finding a positive COVID antibody adds weight to your diagnosis that this baby is actually probably experiencing MISC. So to come back to the baby presented by Dr. Muthomi, like I said, we have been treating the children supportive care, because in our setup, we cannot distinguish this from the usual neonatal sepsis, because I know a question may come from Lois. And of course, we're also careful about antimicrobial stewardship. We're still giving these children Expen gentamicin because the other risk factors for sepsis are still there. So if you ask a mother and the baby could have been at risk, so either prolonged rupture of membranes did not happen with this particular case, or maternal fever or maternal UTI, eye, I think you're still justified to treat the baby with antibiotics, use the guidelines, stick to the first line expungent, which will cover for many of the organisms you're expecting, give supportive care and watch. So to touch briefly on COVID vaccines in children, so there's more interest now in vaccinating children. They tend to have milder disease than adults, but they are still getting infected. A small percentage are getting severe disease, and they are the ones spreading COVID to others. So evidence is needed on the use of the various vaccines, but Pfizer and Moderna, I believe, are now available for vaccinating children 12 years and older. And there are trials ongoing. We hope to be part of one locally for vaccinating children who are aged 6 months to 16 years. However, older people and those with chronic conditions and our healthcare workers and pregnant women remain high priority before we start thinking of vaccinating our children. So the Pfizer vaccine has now been licensed for use. It's now available in the UK, and they're immunizing children who are aged between 2 and 15 who are at high risk, and it's 2 doses given 21 days apart. And children can get vaccinated if they're living with somebody who is at high risk or they have a condition that exposes them to high risk of severe COVID. And I think that is my final slide. Yes, so Moderna is still being evaluated, and we expect results between September and December for use in much younger children. And I think that brings me to the end of my presentation. Yes, thank you very much.
Thank you so much, Dr. Anne-Marie, for an excellent presentation, and also for an excellent case that really demonstrated and highlighted some of the things you've talked about. So if anyone has a question, please feel free to put them up so that we can answer them. And maybe for Dr. Anne-Marie, just one question as we wait for other questions to come in. Is it necessary that we test all neonates born to mothers with COVID? Does it make a difference in what we do, or should we only test those who develop symptoms?
Thank you, Doc. I feel that we should only test those who develop symptoms because often by the time that question, okay, so from the hospital perspective, you start taking the precautions from early on, and if the child remains stable, you discharge them home to continue their isolation there. For the children who are already discharged home and then mom finds out that she's COVID positive, I tell them that in all likelihood, the baby has already been exposed. And if the baby remains asymptomatic and well and breastfeeding, there is actually no need to test that baby. So mother and baby, again, even in the home setting, should just isolate, watch for danger signs, and present to hospital only if there is need.
Thank you very much. I think there's one question here about whether vaccine induced immunity would cross the placenta and whether that would offer any protection to the baby. I mean, you're encouraging pregnant women to get vaccinated. Is there any thought that that protection will extend to the baby?
Sorry, I don't have data on that, but looking at other vaccines which are given in the antenatal period to protect the baby, for example, tetanus vaccine has been in use for a long time. Vaccines for viruses that cause bronchiolitis the studies have gone very far. And again, it's to protect the baby within those first 3 months of life. So theoretically speaking, the antibodies that the mother develops, again, should be able to cross the placenta, particularly if it is IgG antibodies that she has, and should be able to protect the newborn as well.
Thank you very much. I think other questions are coming in, and maybe one for the OBSGYN team. I hope they've been able to rejoin and are able to speak now. And we'll also give a thought from a medical perspective as well. But the issue of role of D-dimers in pregnancy, I guess we understand that pregnancy is already a heightened state of thrombophilia. So the questions of does the D-dimer play any role in pregnancy, and should you routinely do it? So maybe the OBSGYN team can answer that, and we'll also talk about it from a medical perspective as well. I don't know if Dr. Capone was able to rejoin.
I am here, Lois.
Oh, thanks, Prof. Please go ahead.
I've been having challenges of joining, so I had to reuse my phone. I hope nobody will call. Good discussion, good presentations. The role of D-dimers, we know that when you routinely do dimers in pregnant women, you'll find that the levels are usually slightly higher. But we know that what we are seeing in some of the patients who, especially the COVID positive, the COVID infected patients, the numbers always rise almost 3 times the normal. So once you have those high figures, that already tells you that there's a pathological process. So yes, it's elevated, but usually when you find that the figures are going to 2-3 times the norm, please take it that there's something sinister going on, and therefore intervention is usually expected to be put in place. Maybe could I, now that I'm on the seat, could I just make one comment to tie up with what Dr. Maria has just mentioned about the presentation? Now, from the obstetric point of view, there's something which is coming up, which is giving us problems, and I'm sure some of the colleagues may have seen. There are those ladies who come and, sorry, am I on? A phone came in. Can you hear me?
Yes, now we can hear you. You are
yes, sorry, a phone came in. I was using. Now, there are some ladies who come in, they have been exposed. There are even some whom they have got partners or husbands who have tested positive. Maybe they are quarantining at home, and they will never tell you that, look, I've been exposed to somebody who is COVID positive, and they still go through their normal chores, their normal routine, because we have not reached that point where people are really cognizant of what's happening. And these are some of the patients whom you may find that they are delivered, baby start getting complication, baby was exposed, you may get that the baby gets COVID infection, and yet you start wondering where it is coming from. So I think we need also from the obstetric point of view and also from the pediatrician point of view to enhance the effect of ensuring that mothers are usually very open, and they should be able to know what is it that is happening at home front. So this is using phones. Sorry for that. This is the problem of using a telephone line to connect. I'll try and get through. Thank you.
Sorry, Prof, we've lost you for a minute there. Maybe we'll come back to you. Maybe I'll just ask Dr. Anne-Marie one question, even as we wait for Prof to log back in. There was a question that's been asked here about Clexane, and maybe you'll just give us a comment around anticoagulation, prophylactic anticoagulation used in children. If you have a neonate, luckily most of them have mild symptoms, but do you have concerns around coagulation in these neonates as well? And maybe just before you answer, so that I don't forget this one, someone had asked about whether D-dimers are prognostic. In some of the initial work, high D-dimers were thought to be prognostic of poorer outcomes. And initially, people thought that if someone had a D-dimer, then maybe we needed to increase the dose of anticoagulation given. However, subsequently, work looking at outcomes of patients with normal versus high D-dimers and whether that predicted the need for full anticoagulation was shown to be negative in terms of high D-dimers. One are expected because you have you have an acute illness, acute inflammation, but having high D-dimers did not seem to predict the need for full anticoagulation. So in situations where you think your patient may have a PE or something like that, the best would be to do a CTPA where possible. So at this point, many times we're still advocating for prophylactic anticoagulation. So maybe hand over to Anne-Marie and your comments about anticoagulation in children generally, and if there's any time when you think they'll be indicated in a neonate.
Okay, thank you, Lois. So regarding coagulation in children, for younger children, I don't think there are really guidelines, particularly those in the neonatal period, because they do not have the typical risk factors for developing clots. However, for an older child, I have come across guidelines for anticoagulating children in the setting of COVID for children over the ages of, they gave a range like from 5 to 8. And there was actually a scoring system that you could use to see, is the child at high risk? So are you offering just prophylactic anticoagulation or full coagulation? And some of the conditions mentioned included obesity, congenital heart disease, malignancy, sickle cell disease, and then a child who is immobilized and has all of these conditions. So what we have been doing, I think, is on a case-by-case basis. So say we have a child in the PICU who already is showing other signs of maybe coagulopathy, like the term I was looking for that had escaped me is gangrene. You know, the baby is already getting gangrene of the digits. Then I think at that point, anticoagulation can be considered. You can give prophylactic coagulation to a child who is immobilized, so sick enough to not be able to move out of bed. In the neonatal setting, I have not really come across that. So it's older children, and some of them, like one sickler who he didn't quite have DVT, but we suspected on the basis of like sort of some pain in the calves, we actually even discharged him on Xarelto as an outpatient and followed him up and did well. So older children, yes. Neonates, I'm not aware.
Thank you very much, Dr. Anne-Marie. Prof. Ogutu, are you back now?
Yes, I'm back.
You're on high demand.
Now, there's another interesting thing which we need to have more information and we'll coordinate with Dr. Walong's team. What happens, especially in the late third trimesters, in the patients who end up with more complications, especially after getting COVID infection. That's one area of concern. Now, another area of concern which has been highlighted in the presentation of Maria and in the case is that the mode of delivery. It has been something which has been thought about, and most publications from coming over the world, you know, the initial publication and initial management of these patients from one in Chinese studies were more of going for cesarean delivery because people didn't know so much about it. But current studies now show that please look at your patient and individualize. Of the patients who are managed to be delivered through vaginal route, you get less than 5% deteriorating and end up in ICU admission. Those who undergo C-section, almost over 20 to 30% of these patients may deteriorate and require intensive care management. So if you can individualize, make your decision early and deliver the patient so that we avoid situations of ending up in ICU. Now, the big question has always been, what is it in cesarean delivery, which would make these patients now tend to deteriorate? You remember most of these patients have got derangement of the immune system. So whenever you have got any surgical intervention in a patient whose immune system is already being challenged, has got lots of challenges, you therefore end up in a situation whereby these patients tend to have high chances of getting infective processes. And when the infection sets in, then the deterioration in the patient, either from the surgical area, which is a common thing, and also the subsequent maybe compromise of the lung function. And these patients tend to deteriorate very fast. In a number of the patients whom we have had in the mortality sessions, which have been presented either in this webinar or in some of the other webinars in other institutions, majority of the patients who end up being lost are usually the ones who are delivered by C-section. But before you jump to a conclusion that C-section, it almost equates to the patient who will be lost, is simply that sometimes the decision is made too late, whereby a cesarean delivery is done at the last minute. So please let us work as a team, make our decision early, and if need be, bring in all the components early, especially for us obstetrician. We need to bring in the neonatologist much earlier, even before you take the patient to theater, you contemplate delivery, so that a plan of action is put in place. The parents or the family is advised how to take care of the baby, and that makes the whole unit and the whole team having an easier time in management of the patient. Thank you, Lois.
Thank you, Professor Gutu. Excellent summary. So maybe I'll just give a chance to the panelists if they have any other further comments, or if there's a question they've noted that they'd want to comment on. So I'll ask Dr. Ann Barasa, Dr. Walong, if you have any other comments you may want to make.
Great. Thank you very much, Dr. And thank you very much, colleagues, for your comments, Professor Goto. My comment is that autopsies right now for deceased persons where the cause of death is related to COVID are safe. Of course, they have to be performed by a professional team, and they're also necessary to identify these issues that are cropping up. And we would like to receive more requests from the clinical team, and we will engage with the different clinical leaders on how to get additional cases. And we are willing to provide this information back so that you can use it for your mortality meetings, and also to have a better view of what pathology you're dealing with. That is my final comment, and thank you very much again.
Thank you so much, Dr. Walong. Dr. Barasa?
Thank you, Dr. Lois. I think for me, I actually want to just agree with what Prof. Ogutu has just mentioned, that especially when you talk about the mode of delivery, that perhaps it may not be the mode of delivery that's making these patients, get worse postpartum. It just may be the timing. It may be that this patient is already very sick, and it may be the natural history of disease that's predisposing them to the severe illness, and not really the intervention that is being made. So I think we need to approach these patients wholesomely, and probably look at any other underlying risk factor that would make them exacerbate, and so that we can intervene early enough and properly. Thank you.
Thank you very much. Dr. Anne-Marie?
Thank you very much, Dr. and to my co-presenters and Dr. Ogutu and all the contributors. My final comment, I think based on something I saw in the chat, is about the use of antibiotics in the children who are severely ill. So if a baby has come in with what looks like sepsis, or MISC with a multisystem syndrome involvement, again, which can look like severe sepsis, I think there is still a role for you to give your prophylactic antibiotic as you await your blood cultures. But where it is clear that COVID infection is present, I think be careful about just automatically escalating antibiotics as often happens, both within the wards and the other units. So the baby is not doing well, you find has moved from Expengenta, is suddenly on meropenem and other broad spectrum antibiotics, which may not be warranted. So really look at the role of supportive care, which is the main of management of COVID, and even in other severe infections, the supportive care is as important as the appropriate antibiotic choice. Thank you.
Thanks, Dr. Anne-Marie. I can see how you're trying to tread the thin line between stewardship and managing a very sick child. But thank you very much for that response. I think there was just one question about, is there a need for junior aspirin and Xarelto in outpatient management? The answer is no. We do not need junior aspirin in outpatient management. Xarelto, again, the general answer is no. Having said that, remember you must manage your patient. So if you have a patient who's at high risk for ongoing coagulopathy, this would be a patient who's recovered from severe COVID, is unable to move, may have an underlying malignancy, or is known to have a coagulopathy, then you must make an individualized decision about whether ongoing anticoagulation is necessary or not. But for a patient who's well, who's leaving hospital and walking around, there's really no need for ongoing anticoagulation beyond discharge. All right, so I think we will stop there unless there's another comment. Allow me to thank all the panelists for excellent, really excellent presentation. It was interesting being taken back to class and learning pathology again. Thank you very much, Dr. Barasa, for that. Dr. Alon, we look forward to even seeing further results for your work. Dr. Anne-Marie and Dr. Mutomi, I know you guys have done an excellent job in managing even children, especially in this last wave when there were a number of children who had COVID-19, and thank you for all the answers you provided on this forum. Thanks, Dr. Thuranira and Dr. Kosgei, for so ably organizing and bringing the group together. We appreciate you all. Have an excellent weekend. Bye.
Bye.
Bye-bye. Thank you very much.